pediatrics. Now, during this time, 1950s to 1970s, in various fields of general practice, including medical care, primary care, nursing care, social work, in developed Western countries where these fields and professions are being advanced, people, clients, patients are becoming more and more informed, empowered, and a little more demanding, meaning they are demanding more equal footing in the helping relationship, meaning they don't want the provider or the counselor to just tell them what their problem is and what they should do about it. They want an equal and more active role in the entire process. And so you have the development of the patient-centered approach in general practice, in medicine, nursing care, social work, pastoral care, and many more. In general practice, general medicine, family practice, primary care, pediatrics, social work, in the patient-centered approach, the patient's individual needs and desired outcomes are the driving forces behind all healthcare decisions and quality measurements. So just like Carl Rogers, who was reacting to the commonly accepted therapeutic procedures during the 1940s, where the provider or the counselor gives the advice, the suggestion, tells the patient or the client what to do, tells them the diagnosis and the interpretation. In the 1950s, 1960s, and 1970s, the care providers and the patients or clients are also reacting to the same thing. And so we have a patient-centered approach in general practice, which is more collaborative, pays attention to the patient's preferences, values. It's more holistic, meaning since the patient's individual needs, desired outcomes, and experiences are very important, then the client's emotional, mental, spiritual, and social and financial concerns are taken into consideration, meaning the care providers should not just tell everyone the same thing and disregard their individual needs, desired outcomes, and values, and thus the label person-centered or patient-centered approach in general practice. So the big question is why? Why will it work? Why does it work? Well, we know it does work. The question is why. There are several sophisticated ideas and variations of these ideas and explanations, but a simple way is to start with the humanistic ideas of the person or the patient having the internal capacity to grow as a person and solve problems. As an illustration, consider a student in college who's trying to become a care provider. Now, he has very poor grades and he feels like he's about to fail his course. So there's a discrepancy, an incongruence between what he wants to become ideally, his ideal self-concept, and what's actually happening in reality as far as he sees it, his current self-concept and perception of reality. Now, he might feel very helpless, powerless, very anxious, unable to study, unable to make decisions. He's feeling threatened and very vulnerable, and he needs help. He needs to deal with these obstacles blocking his growth so that he can move forward in a positive way. Carl Rogers believes that success is achieved when the patient or the person becomes more open to experience, begins to trust in themselves more, internally assess themselves, and again becomes more confident and willing to grow as a person. Actually, research has shown that the provider or the counselor's attitudes are more important than the techniques, knowledge, and theories. It is really the therapeutic relationship or the helping relationship that counts. Why is it more popular among counselors and less among psychiatrists and psychotherapists? There are several reasons, but some are very easy to see. If we look at the popular approaches of psychiatry and psychotherapy, the person-centered approach appears to be very simple or simplistic, and so there's a concern if it actually works well in more pathological cases. If the case is too pathological and the counselor or the provider is very non-directive, will it still work? Actually, some studies show that it does, but I would guess there's a certain threshold of pathology where being more active and directive is required. The other reason is Carl Rogers realized the significance and potential usefulness of person-centered approaches in education, medical care, healthcare, politics, organizations, companies, churches. Actually, in the 1980s, he even felt that this approach can help achieve world peace. So the focus really shifted to non-psychiatric, non-pathological, non-structured, and non-traditional areas. Areas of interest among counselors, counseling providers, doctors, nurses, social work, pastoral care, human resource, and areas which are less interesting to psychiatrists and psychotherapists. Finally, in psychiatry, neuropsychology, and many areas in medicine and healthcare, there's more interest and focus on the disease, the pathological, the organic etiologies, and the drugs and medications, and more physical interventions to address them. And obviously, we don't find a lot of those in the person-centered approach. And so now we can ask in medical care, nursing care, social work, pastoral care, in the way our profession cares for or helps people nowadays, the question is our helping relationship relationship really person or patient-centered. From 1970s, 1980s onwards is the helping relationship or the therapeutic relationship in our own different caregiving professions becoming more patient-centered or becoming less person and patient-centered. Unfortunately, for some fields, evidence-based or scientific study-based practices, quality care, quality monitoring and control, standardization of practices, professionalization, standardization of training, competencies, skills, tended to focus on stuff that can be generalized, stuff that will apply to everyone or most of everyone, and focus less on individual lives, perceptions, experiences, values, preferences. This is very noticeable in healthcare related fields. And the next question is, assuming there's a particular profession that is patient-centered, the question is it or can it be Rogerian, and in what way? Well, it can be Rogerian if it's somewhat non-directive in its methods and approach and spends some time and effort trying to actively listen and understand the client and the patient. Unfortunately, in places where healthcare is becoming more and more of a business or a big healthcare industry, businessmen and business-oriented providers would look at these approaches and methods as very time-consuming and not very efficient. In their minds, they can do things more quickly by doing quick, efficient, focused assessments and then telling the patient what needs to be done. And then we can ask, are we client-centered as far as Carl Rogers is concerned? Meaning, is there an attempt to understand the patient's personal experiences, perceptions, internal frames of reference, and not just understanding, but understanding with empathy, as well as unconditional positive regard for the client or the patient? If this is the case, then Carl Rogers might be okay with us calling ourselves Rogerian, although he would be happier if we just call it client-centered and not use his name. And then finally, we can ask, is it humanistic? And not just because we treat our patients as human beings, but based on what humanism and the humanistic approach is and how they are actually defined. Meaning, as doctors, nurses, medical social workers, care providers, when we deal with our patients and clients, do we think of freedom, choice, values, personal responsibility, autonomy, experiences, perception, sense of meaning, sense of purpose in life? Do we think that we know best, or do we think that they know best? Do we trust our clients' or patients' ability to move forward in a positive manner, to make positive and constructive and helpful decisions? As care providers, how much power and control do we want out of the caring or helping relationship? Or are we willing to empower our patients and clients? Unfortunately, a lot of professions in health and medical care are becoming less and less humanistic.